Greetings, everybody. Welcome to this webinar series. He whakawhanaungatanga o te whānau o Te Huringa Mahara ki timatanga ahau I te tuatahi. We'll just introduce ourselves and I'll go first. Kia ora anō, he uri au o te iwi o Ngāti Parau, ko Gai Baker toko ingoa. He mahi au ki Te Huringa Mahara, he kaitohu whia ko Māori, Principal Advisor for Māori whānau lived experience. Nō reira, kia ora nō tātou, and I'll hand you to Natalie.
Kia ora koutou, ko Natalie Horspool toko ingoa. I'm a Principal Advisor at Te Huringa Mahara, and I was one of the co-authors of this report presenting to you today. Kia ora. Passing on to Tanya.
Kia ora koutou, ko Tanya Maloney toko ingoa. I'm Director of Mental Health and Addiction System Leadership with Te Huringa Mahara. I'll just hand over to Katie to introduce herself and she'll hand it back to me to talk a little bit about the context.
Awesome. Kia ora koutou e te whānau, ko Katie Sheriff toko ingoa, he kai tohu mata moa o Te Huringa Mahara. So I'm a Principal Advisor at Te Huringa Mahara. I will be in the background on the chat, saying nice things, replying to questions, and I'll be facilitating the Q&A session at the end. Take it away, Tanya.
Thanks, Katie. Look, I know many of you have joined our webinars before, but I'm going to give you just a little bit of context about who we are and particularly our monitoring function. So we were established in February 2021, so we're 2.5 years old, and we're established to contribute to better and equitable mental health and wellbeing outcomes. We were established in response to He Ara Oranga, the government inquiry report into mental health and addiction. And we are an independent Crown entity, so we sit outside of the system. We have an oversight and system level monitoring and leadership role. So we're not a part of the system, but we're certainly involved in helping the facilitation and contributing to the transformation that we want to see for more equitable mental health and wellbeing outcomes. We have really important obligations under Te Tiriti o Waitangi in our legislation, and we have committed to being grounded in Te Tiriti o Waitangi. So that commitment is reflected in all of our mahi, and it's certainly reflected in the way we do our monitoring and our reporting. Part of our monitoring function is to make recommendations and also to advocate for improvements to the system. So that's really important in the context of the mahi that we're talking about today. And our other really critical advocacy function is related to the collective interests of people with lived experience. So in our work, we prioritise bringing forward the voices and the perspectives and the experiences of those people and whānau who have experienced mental distress or addiction and had access to mental health and addiction services. So our monitoring function, if we move to the next slide, is led or framed by our He Ara Awhina framework. And this is a framework that was developed over the course of about 18 months and published in June last year. We used this framework for the first time in our Te Huringa Tuarua report that Natalie will speak to in a moment. The important and really valuable part of this framework is that it has a Te Ao Māori perspective and 6 domains and aspirations that are developed by Māori about what good looks like in the mental health and addiction system. It also has a shared perspective and the 6 domains that align with the health quality domains of the Institute of Medicine, but it is written again from the perspective of tangata whaiora, of people with lived experience and their whānau, about what good looks like from a system perspective to those people who access services And this is the framework that underpins our reporting work and indeed our advocacy work. I'll pass to you, Natalie.
Kia ora. Thanks, Tanya. So as Tanya mentioned, we have a legislative function to monitor mental health and addiction services, and this function was transferred over from the Health and Disability Commissioner in February 2021, when we were established as an independent Crown entity. So our second monitoring report, Te Huringa Tuarua, was released in May of this year. So this is the cover of this report. It is a national level monitoring report, and we monitor across a large set of 86 measures to monitor service performance. So using this data, we explored what has changed in mental health and addiction services over the last 5 years and where further work is needed. This report also included some case studies on services that are showcasing excellent work in the sector. So the scope of our monitoring for this iteration included Vote Health Specialist Services, primary care, national telehealth services, online platforms, and some emergency service measures. And we do our monitoring on a financial year basis. So in the next few slides, I'm going to step through some selected findings about what the data shows about mental health and addiction service access. So this is a short webinar, and we're not going to be able to cover all the findings that we covered in our Te Huringa Tuarua report, nor can we cover the detail about all population groups. So if you are interested in this further detail, please refer to the report that's on our website. And also next month, we're going to be releasing a dashboard, which is accompanying this report, and it has a wealth of data where you can filter and analyse by different priority population groups and over time. So a lot of that further data will be available next month that will be published on our website. So I'll start first with the positive findings from the report. So firstly, there's wide evidence to support that there are services widely available for people who are experiencing mental distress or harm from substance use. And there are new options available, such as the Access and Choice program. There were 114,000 people who accessed Access and Choice program services in the 21-22 financial year alone. So this rollout of the Access and Choice program is significant, and it's an expansion of primary mental health and addiction services. The aim of the program is to provide free and immediate support for people who have mild to moderate mental distress or substance use harm needs. And it's provided in a range of settings, including kaupapa Māori, Pacific youth services, as well as general practice and other community settings. Also positive that we've seen a significant investment in mental health and addiction services. So expenditure has increased 33% over the 5-year period of our monitoring. And there are more funded workforce positions. So for example, in adult specialist services, there were just over 11,000 positions in 2018, and this had increased to about 12,500 in 2022. So the data shows in our report that there have been fewer people using mental health and addiction services in the last year of our monitoring, and this is across many different types of services. So this decrease in service use is in terms of both number of people and also percentage of the population. In specialist mental health and addiction services, service use declined from 3.7% of the population in the 2020-21 financial year to 3.4% in the 21-22 year. And the decrease in specialist service use was greater for younger people, Māori, Pacific peoples, and people using addiction services. We've also seen this decrease in the number of people using national mental health telehealth services. So these telehealth services are those provided by whakarongarau and include well-known services such as the 1737 helpline. Other primary mental health initiatives have also decreased in the last year of monitoring. So these are services provided in general practice that come under the dedicated packages of care and can include extended GP or practice nurse consultations, brief interventions, individually tailored packages, and group therapy. Our monitoring also found decreases in online platform use in the last year, including depression, the lowdown, and the level. So the exception to this decreasing trend is the increase in the number of people using the Access and Choice program. So the new services that I mentioned just in that last slide. So you may be thinking about what this means overall. Are more or less people receiving some form of support from a mental health or addiction service? We do not actually calculate overall net increase or decrease for a few reasons. Instead, we focus on the change in service use for individual service, each type of service. So the reasons for this are, firstly, some of the data sources are not linked to National Health Index numbers, and so we cannot do a unique count of number of people. Many people use multiple services, and so we would be double counting if we did this. Second, a large part of the increase in service uses come from the Access and Choice program, and so the data systems for this program, as it was a new program, were understandably poor in the early years. So the numbers for the first few years are estimates, not actual number of people. And third, we don't think it's appropriate to count overall people as the level of acuity is different across the continuum of care. You may also be thinking about whether the Access and Choice program is the reason why there's been a decrease in specialist service use and other primary mental health initiatives. And yes, one of the aims of the Access and Choice program is to provide easy to access early intervention to take the pressure off specialist services in the future. But we consider that it's too soon in the rollout of the Access and Choice program for its impact to be fully explained the decrease in other parts of the system. So as at June 2022, just under 50% of the population enrolled with a GP had access to an integrated primary mental health or addiction service. We would also not expect the Access and Choice program to result in less people accessing other primary mental health care. The Access and Choice program was designed to provide support to people who had previously not been able to access services, the so-called missing middle. So in terms of other parts of the system, the data in the report shows that there continues to be substantial increases in mental health medication dispensings, particularly for young people. Here at Oranga, the 2018 Government Inquiry into Mental Health and Addiction emphasised that while medication is important, it's only part of an approach to mental health and addiction support, and it needs to sit alongside a range of other forms of support and treatments. Another interesting finding is about mental health related emergency department presentations. So when people don't get their needs met from mental health and addiction services, EDs can at times become a default entry point. So this graph here shows that while mental health presentations at ED increased steadily over the 4-year period to 2020-21, they then fell by 12% in 21-22. And this decrease is both in terms of number of ED presentations for mental health reasons and the percentage of ED presentations that are mental health related. This decrease in service use in parts of the system is unexpected, given the public reports of increasing levels of distress. The New Zealand Health Survey data shows that the proportion of people with high levels of psychological distress increased 8.6% in 2017-18 to 11.2% in 21-22. This is for people aged over the age of 15. And this increase is high for some groups, such as Māori, young people, and people living in deprived areas. The New Zealand Health Survey data also shows that the level of unmet need for mental health professional help has also increased over time. And so this data at the very least shows that need is not reducing. However, despite having the New Zealand Health Survey data, there's still not a comprehensive prevalence survey on mental distress and substance use harm in Aotearoa. So you may know about the last survey, Te Huringa, conducted in 2004. So that's now significantly out of date, nearly 20 years old. So without this comprehensive prevalence data, we cannot say whether the decrease in use of some services in parts of the system reflects less need for services or whether it reflects greater barriers into accessing services. So what can we say about why service use has decreased in part of the system? We have over the last 4 years seen significant increases in workforce vacancies, and this is widely reported. In adult specialist services, for example, vacancies have doubled from 5.5% in 2018 to 11% in 2022. While specialist services are seeing fewer people, tangata whaiora may be experiencing more acute distress or more complex situations. The average length of stay in inpatient units has increased, and the rate of people seen within 48 hours by former DHB mental health services has also increased. So this suggests that people that are seen for the first time are also experiencing more acute distress. Rates of decline referrals into specialist services are relatively steady over time, and as are the wait times into specialist mental health services. Although, as a side note, noting addiction wait times have slightly increased. So from this data, we cannot see evidence for greater barriers or demand exceeding capacity. It is possible that the COVID-19 lockdowns from August through to December 2021, particularly in the northern regions, had an impact on access to services. And as mentioned earlier, the rollout of the Access and Choice program will mean that some people are getting support they need earlier. However, we think it's too soon to fully explain the decrease in other parts of the system. So it's fair to say we don't yet have a full explanation of what's going on with this decline in service use in some services. So this is a topic we're currently working on to explore further in our next 2024 report. And I'll talk a little bit more about our plans for this in a few slides. All of our data that we gathered from agencies and output has been disaggregated where possible by ethnicity, age groups, and service types. So this slide shows some selected findings on service access for Māori. Māori have higher rates of specialist service use. In the last year of data, 5.6% of the Māori population access specialist services compared to 3.4% of the total population. The New Zealand Health Survey's data also shows Māori have higher rates of psychological distress. However, again, noting that without the comprehensive data on the level of need, we can't comment whether access for Māori is in line with the level of need. Māori have higher referral rates into specialist services from the justice sector, and together these findings suggest that Māori do not have the same access to early intervention supports and services and are more likely to be referred into specialist services with acute need. However, there's some positive findings and encouraging to see improvement for early access for Māori, with relatively high numbers of Māori accessing some of the Access and Choice program services, particularly youth services. And another positive finding is the increased expenditure on kaupapa Māori services, which, as you can see here, has increased from 151 million to 212 million over the 5 years. Also looking specifically for young people, there are two key findings in the report are that young people aged 0 to 18 years have longer wait times to access specialist mental health services than other age groups. And we also found the largest increase in dispensings for mental health medications were for people aged 0 to 18 years. So we want to see that young people have improved wait times and have a range of options available to meet their needs. So this is one slide that summarises everything I've just spoken about. So there's quite a lot of detail here, which is why we've stepped through it. But this is a visual summary of the previous findings. And this infographic is also available in the report that's on our website. So you may be asking whether the data is correct that we're presenting here. And yes, all data has quality limitations, and this data is no different. Primed, for example, which is the National Data Collection for Specialist Mental Health and Addiction Services, does have known data quality issues. For example, the May 2021 cyber attack impacted Waikato DHB's reporting into Primed. And likewise, there are other issues with other data collections we've drawn from, such as the Primary Mental Health Initiative data. So this data is collected manually from former DHBs and it's not NHI linked, so some double counting may occur. However, overall service use patterns do remain after removing, say, for example, Waikato DHB, and our monitoring brings together data from a range of sources to triangulate findings. So we conclude that the decrease in some parts of the services is partly due to data incompleteness, but it does still represent real change on the ground. Nonetheless, in our report, we always call out areas for improvement, including the vital improvement on data collection and reporting. We continue to have a data advocacy role, and this data is critical for monitoring purposes. We need accurate data to have evidence base to influence system transformation and to contribute to better and equitable mental health and wellbeing outcomes. So I mentioned a few slides ago that we're planning further work to investigate what's going on with service access and options. So we're currently in the early stages of a report looking specifically into this topic. It will be more of a deep dive into this domain of he ara āwhina, unlike our 2023 report, which was across the breadth of the he ara āwhina framework. So this 24 report will be released by June next year, and it will draw from additional data to explore the topic more fully. And we're also planning a primary data collection component to include the views of people working in the sector and community perspectives. The data collection component of this goes live later this month, and we'll seek community perspectives mainly through an online form. So we'd really welcome your help sending this out to people you may know who want to share their experiences about trying to access mental health and addiction services. The online form will be on our website, sent to our stakeholder list, plus many other dissemination approaches. We'll also be conducting interviews with key people in the sector to understand workforce perspectives on service access and options. So if you work in the sector and want to share your views, we're always welcome to hear from those, so please reach out. As always, contact us at kiora@mhwc.govt.nz. And I'm coming to the end of the formal presentation part of this, moving into the question and answer time. But just one final note to end on before we do is just acknowledging the thousands of staff that work providing mental health and addiction support to people every day. So particularly acknowledging this time of health reforms and workforce challenges.